Hi there. Yeah, I actually attended the meeting in 2019, and I talked about anthrax toxins also. At that point, we'd had a method for anthrax lethal factor for some time, and we've been asked to do a lot of animal studies with collaborators. And so we thought animal samples are extremely valuable, especially non-human primate samples. And so we wanted to make sure that we could analyze a full suite of anthrax toxins to get as much information out of animal study as we could. And so today I'll be talking about some of the work we've done with BARDA, which is part of HHS in the U.S., and the National Institute of Health on some of the work that they've done on animal studies. So today I'll talk about a little background about the anthrax toxins, and then we'll look at some data from non-human primates, some of the more recent anthrax human clinical cases, and then kind of an interesting development which has happened later, and this is anthrax-like disease from other members of the Bacillus cereus groups that have picked up PX01 genes, and now we're giving an anthrax-like disease. There's 5 forms of anthrax that are kind of recognized now. 4, they're caused by Bacillus thurensis, and then the Weller's anthrax from Bacillus cereus groups. Cutaneous anthrax, case fatality rate of about 20% unless you treat it, and then it's less than 1. This is about 95% of cases that we see worldwide, especially in places like Bangladesh every season. Because they just have a lot of anthrax spores around that you see a great number of cases. There's gastrointestinal anthrax. That's a case fatality ratio of 25 to 60%. We don't see much in the U.S. We had a couple of cases. Probably most famous was a woman in New Hampshire who had went to a drumming festival. One of the drums had anthrax spores on it. She laid her sandwich on it, ate the sandwich. She probably still would have been okay, except she had hookworm, and that then allowed the anthrax to grow in her gut, and we were able to detect it in her blood and her ascites and follow her treatment. Inhalation anthrax, that's usually fatal without treatment. The case fatality rates, even with treatment, can be quite high. In this feedlots incident, it happened in 1978. I don't know if anyone's familiar with that, but in the old Soviet days, they had a bioweapons plant, and a worker had was changing out the filters on their dryer where they dried the spores that were going to be weaponized. And he noticed it was quitting time, so he put it down and then put the new one back on. Wrote a quick note that says, "No filter, don't turn on." The next guy came in, couldn't figure out why it wasn't on, flipped it on, and it blew spores out into the village that supported the plant, including their workshops. And as I say, about 86 to 89% of the affected people died from that. Supposedly the Soviets weren't real open about it. They went by, they gave everyone antibiotics and said, "We think you ate contaminated meat." Well, they didn't eat meat, but anyway, that's what happened there. But even in the U.S., it was 45% of the people who got anthrax letters, and this is with the best top rate, and people were ready for it. Supportive care. About half the people ended up dying from the inhalation anthrax. There's also injection anthrax. We see this from time to time. Probably the biggest case that we've been involved with was the one in Scotland, in Glasgow, in about 2010. They're basically heroin had come out of Afghanistan into Turkey, got wrapped up in animal hides that just happened to have anthrax spores. I don't think anybody knew it, and it got imported into the UK and sold up in Glasgow, and many people died on that. That had a case fatality rate of 25%. The thing about that was that some of the heroin users used it in the arm, and then they showed big black things, and people noticed, and they got taken to the hospital. Other ones shoot it in the groin, and so that's kind of hidden, and so they had a much higher fatality rate than the ones in the arm. And then the Weller's anthrax has a terrible case fatality ratio of about 70%. So, and then we'll talk more about that in the end. What is inhalation anthrax? Well, I think those spores are put it in the lungs. Initially resembles cold or flu, so it's a little bit hard to diagnose initially. And it's been described, and this is, you know, going all the way back to the days it was called in the UK, it was called wool sorters disease, because people handling wool would sometimes inhale spores. But they, you know, there's an early predominant where patients become rapidly ill. That's the flu-like symptoms. Then intermediate progressive, that's where they actually seem to be holding or even sometimes getting better. And then they turn a corner and late filament, and they become rapidly ill and die. And it's been described in a lot of detail. The toxins that are responsible for all this morbidity and mortality are basically two binary toxins: lethal toxin and edema toxin. Lethal toxin cleaves MAP kinases, and that basically causes lysis and cytokine modulation, stops signaling between cells, and is reported to largely wipe out your immune system. The edema factor and protective antigen, they bind together, and then they'll actually bind to comodulin, use that calcium to turn ATP to cyclic AMP. Is a very fast enzyme. It's amazing how many turnovers you can get on that. It causes edema, and that's often the patients will bleed out because of the leakiness of the cells, which is kind of working between these two. So in early infections, as I mentioned, it disrupts your immune system, and then late in infection, you see collapse of your endothelial cells, hemorrhage, shock, and death. The mode of action of them is that you it's thought to happen on cell surface, but a lot of this could happen in serum itself. It binds protective antigen, and then there's a furin cleavage site that made up of an arginine, two lysines, and another arginine. That's why it could actually have serum too, because trypsin-like enzymes could cleave that also. But once that's cleaved, then it becomes PA20 goes away, and this 63 kilodalton protein that's left becomes either a heptamer or octamer, and then that combine either 3 or 4 EF or LF onto the cell surface. The endocytosis goes in. There's a pH change. This is mechanism you see over and over, I know, in toxins. So, and then basically the EF and the LF will go into the cytosol, bind to comodulin, or find a MAP kinase in which it will cleave it, or turn ATP into cyclic AMP. So as we have developed methods for all these toxins, there's a huge range of detection limits based on the method. So we use a lot of time, use the enzymatic activity, very much like Susie showed with ricin, but those give us a better one. So we can now detect 30 attimoles per mil, which is 2.7 picograms per mil for LF. For EF, it's way below that. It's in the zeptomole per mil. We have to use a very classic way for protective antigen, so it's 1.2 nanograms, and so it has a much higher detection limit. So, and you'll see the consequence of that. So we can do, as I mentioned, lethal factor, and we can do total lethal factor that's bound and unbound because we have antibodies to pull it out. We can do edema factor, which is bound and unbound because we have antibodies that can pull it out. Or we can do just protective antigen antibodies. We can get just lethal toxin and edema toxin, and then the free PAs, and they can all be measured separately. So it's kind of broken up into 3 different groups. And this is just what some of the data looks like. So this is an early study with recent macaques. Now this is a log scale. So imagine that it's going from 10 here up to almost 10,000 there. So it's a lot, as I say, a log scale. And so as you see the edema factor, is actually a couple of orders of magnitude, about 3 orders of magnitude lower than the lethal factor. Lethal toxin always lags behind because it has to bind to the protective antigen, and it's about an order of magnitude lower throughout. But they all kind of match up with all the lethal factors in the lethal toxin mode, latent infection, and the edema factor actually catches up to be very close to the lethal factor. So it's like the lethal factor and lethal toxin come out early, and then the edema factor kind of comes out later, which is kind of how the immune system is wiped out, and then the bleeding out occurs. When we were working on some studies with cynomolgus macaques, cynos, we actually saw a very clear demarcation. There's ones that react very quickly and die, and ones that will go longer. And the ones that go longer, this is at phase 2, where they're kind of holding, or sometimes they're even improving. It's very tight. It's amazing how little variation there is in concentration between all these animals. This is probably equivalent to the 45% that couldn't be saved in the anthrax letters because they got so quick, so fast, whereas these went out much longer, which means you have much longer to treat before you kind of go over this point of no return, which we're calling the critical toxin index. Once you go over that, you go into phase 3, and it seems like antibiotics can't rescue you. And right now we're doing the studies on New Zealand white rabbits to see how the antitoxins work, but it's looking right now it's going to be the same kind of pattern. One thing that we had hoped that we could actually look at how much PA83 there was and how much PA63 there was, and tell what phase of anthrax you were in. However, at all phases of anthrax, PA63, processed one, totally dominates. There's hardly any of the PA83, the long one. That's why we're thinking it probably gets activated a lot in serum, because it's just too quick to be all cell surface. And so this is kind of what the results look like. And this is just kind of a representation of what the data for the different progressors. So you have these long progressors that go in, but once they cross over this threshold, it doesn't matter if you're one of these fast progressors or one of these slow. You have an average for all these groups. The average was 21 hours for both of them, from the time they cross over that threshold to when they're dead. And so it's kind of interesting that it's like once the toxin level hit a certain level, that's kind of the end. We also looked at tissues for those that get sepsis and basically multi-organ failure. You see it in all of them: kidneys, livers, lung, lymph nodes, spleen, a little bit in the heart, and they're still in the plasma. For those that get meningitis, so that's another pathway that you see with anthrax. A certain percentage get meningitis, and that's actually one of the more deadly, less curable ways that the disease can progress. It was almost all in the brain. Or in the plasma, and very little actually in the other organs. Now, when we started looking at treatments, so this is treatment with an antibiotic called Cipro, and this is an average. I'll show you individual data, but those are treated at 48 hours. Everyone that went over that threshold ended up dying. Everyone that stayed under the threshold ended up living after they got Cipro. And this is for LF, LTX, PA, same thing for edema factor. And if you look at the individual animal, you'll see they all kind of stayed below. This is the lethal factor, which is my favorite one. You see they all stayed below kind of the threshold. Everything that went over, even just a little bit, ended up going through and not surviving. This is a clinical case. This was someone from Minnesota that went out. He owned a jewelry store, and he liked to go hunting gems and rocks. And so he went to North Dakota and started digging up rocks, and somehow he inhaled anthrax spores, probably from an animal that had died, a long time ago. But they gave him his antibiotics, and it came down. Now remember, this is a log scale, so it's coming down rather quickly. Then he got the AIGs, which are antibody-based antitoxins. It fell down, and this is what you want to see. His pleural fluid was coming down very nicely, and his antibody levels, his anti-PA antibody level, just started to tick up before he actually received the treatment, but then they went up and they stayed up. What you see when it's unsuccessful is, and I don't want to show any unsuccessful ones, but they actually come down, they go back up, and the antibodies go up and they come back down. And I know in Scotland, we saw a lot of those. And then depending on what's going on clinically, sometimes you'll see the levels start bouncing around because they're bleeding out, they're getting blood, they're having surgeries, they're getting blood. And so the concentrations keep on changing at the end. This is kind of what the average looks like. Inhalations are the highest, injections are next, then the GA and the cutaneous. And then if we had welder's anthrax on here, it would be the highest of all of them. So a couple things have happened over the last several years. One is the discovery of something they're calling B-series biovaranthasis, and this is in Africa. It was basically finding great apes that died in Cameroon and Cote d'Ivoire. And they harbor two plasmids, both the PX01 and PX02, like plasmids right there. And they're highly similar to Bacillus anthracis. So the PX01 makes the toxins, PX02 makes the polygamma D glutamic acid capsule. And now, as they've been looking through Africa, they're finding it in chimpanzees, gorillas. They got one elephant. They got a bunch of goats that have it, and it's throughout West and Central Africa now. So kind of grown and where it's been found. In the U.S., we have something a little bit different. It's called welder's anthrax, and that's inhalation anthrax-like infection, and it occurs in welders and metal workers so far only. There have been 7 inhalation cases reported in the U.S. All of them but 2 were fatal. 5 of them were welders, 2 were metal workers, 4 of them were in the state of Texas, and it was along the Gulf Coast of Texas, and 3 of them in Louisiana, which is along the Gulf Coast of Louisiana, right near the Gulf Coast of Texas. So there's also a cutaneous infection in Florida, also on the Gulf Coast, and that was the first one that we actually showed that that one was early on, and we showed that it was made tox in it. So this is a recent one that came from Louisiana. The guy lived in Mississippi, but he worked in Louisiana, and you see it's up to 1,000. That's a microgram per mil. I mean, that is really high. And the antibiotics brought him down. You got Raxi, it dropped it. Raxi is a monoclonal antibody that is treatment. Dropped it, and then he continued to go down. He got a second dose of Raxi. He was on death's door. And so it was kind of a Hail Mary, but also we still were detecting toxin in his pleural fluid. I continued going down, and his antibiotics went up and then fell a little bit, came up with a second dose, and stayed up reasonably well. But it was the highest levels of lethal factor we've ever seen in a case. And he did get the second shot of Raxi, but this is because of his continuing instability. I mean, he coded 3 or 4 times. They had to restart his heart. They had to restart his lungs. And then he was 3 months on a ventilator, and he's had to go to rehab. He's back at home, but understand that he's not going to ever be the same. So it's kind of a sad case that we still don't understand why this is only in welders. not sure if it's welders are more susceptible to lung diseases anyway because of the metal fumes and everything. Plus, this particular individual, he was a chain smoker and he drank 6-pack of beer every day, and so he had other lifestyle issues. Just summary is we still think lethal factor is the most reliable. It's the earliest found with our detection limits. The toxin and the ratio of toxin levels, LF to LTX, LF to EX, really do tell you kind of what stage of infection you're in, and kind of the toxins really early in your infection, into phase 1, a few days in, are what really determine your outcome and how successful you're going to be with treatment. So if anyone had any questions.